Good morning, Don. Good morning, Jean. Thank you for joining us today.
Sure.
We'll be starting here in a few minutes.
Good morning.
Hey, Jean, how are you?
I'm good, Don. Good to see you again.
Hi, how are you? I'm Julia. I'm going to be moderating for today.
Great. You did a great
Very
job
good.
in the last session.
Oh,
Thank you. Thank you, Julia, for jumping in and introducing yourself. Thank you.
Do you guys have any PowerPoints? Do you want to do a screen share test real quick of your PowerPoint?
I'm trying to share my screen now, and it doesn't seem to be doing that.
Okay, I think I just have to enable it. 1 second. Try. You can try it now.
Do you see it?
Yep, we see it.
Okay.
So you can leave it like this, unless you just want to unless you want to introduce yourself first, then open up the PowerPoint, whatever you prefer.
Whatever you like. I'm not sure I can always manage it. Okay, we'll see if we can make this work. I should be better, more skilled at this than I am.
Okay.
There's an awful lot of background noise.
Yeah, I'm going to mute myself now because I'm in a noisy place.
Robert will be doing the same thing, putting the upcoming screen on while as we start to let people in, and then I'll give my welcome in about 2 minutes.
Well, actually, everyone's already in because we used the same meeting from earlier.
Ah, okay.
So we're ready to go.
Well then, welcome back. I should be used to this too by now. Welcome back, everyone, for session 2. I'm going to turn things over to Don and Jean. They're going to talk more about the more advanced stages of MSA and what needs to be done in those cases. Good morning, Don and Jean. Thank you for participating, and you're on.
Okay. I'll kick off since I'm the more senior of the pair of us. I'm Don Pendley. I'm Director of Hospice and Palliative Care for the Home Care and Hospice Association of New Jersey. And prior to that, I was president of the State Hospice Association, which merged with that. So all in all, I've been doing this advocacy work for 27 years, and it's been very rewarding. And I've had the pleasure of speaking before MSA on a number of occasions. So it's good to be back with you. Jean?
Hi there. I'm Jean Chirico. I'm the president and CEO of the Hospice and Palliative Care Association of New York State. And prior to my working with the association, I was a hospice provider for 27 years. So I have been a social worker and a volunteer, bereavement coordinator, spiritual care, all of the above, until I ended up running the program. So I hope that we can offer you some helpful information today and especially answer any questions that might be of particular importance to you.
Well, as you just heard, Jean's been at the patient bedside even more than I have, so it's a real pleasure to be with her. Let's pray that I can start the slides. There we are. Jean, it's all yours.
Okay. So Don, feel free to move the slide along to maybe the 3rd slide, I believe. There we are. So what is it that you need to know? Well, probably more than we could cover in our hour today, but I think our goal is just to set the groundwork for acknowledging that when you have a serious illness, there's no real linear timeline. many things can happen that you feel like you're stable and doing well, and then you feel like you might be not doing well, and these ping pong can go back and forth for a long time. So that straight line of patient progress is kind of an illusion there. It's not a straight line. But the beauty about palliative care is that it doesn't have to be in a straight line. So as someone has a serious illness that continues to progress, and the needs continue to progress in terms of symptom management, sometimes coordination of multiple providers, and also looking at the medication interactions. These are all things that might fall under a palliative care component. So while someone is still seeking, could be curative care, it could be ongoing maintenance care, they might also be receiving palliative care to assure that all these items are being addressed, in addition to some of the psychosocial issues that you experience throughout the course of your illness. And then when a person is nearing the end of their life, as best as someone can tell, when they are at a point where they no longer want to be hospitalized or to use aggressive treatment to extend their life expectancy, and they'd rather just focus on quality of care, comfort-oriented care, and all the supports that can be made available for their spiritual wellness, etc., then they may decide to elect hospice. And we'll describe the specifics of that as we go through our presentation. And when someone elects hospice, one of the benefits is also bereavement support for your loved ones. So hospice in and of itself, in terms of the definition of hospice, according to the Medicare benefit, must include bereavement services. So it's a natural component of hospice care. Okay, Don, you want to take this one?
Oh, okay, sure. Hospice and palliative care, they are similar in many ways and they are different in some ways. And we're going to lay out in the next few slides those similarities and differences so that hopefully, should you ever need either or both of those services, you'll have some better idea of what you'll be getting. Hospice is a type of palliative care. Palliative care works toward the comfort of the person, the patient. The techniques of hospice and palliative care are very different. Both of them seek to provide comfort. The differences lie in who is served, the traits of that patient, how the programs are organized, and how that care is paid for. The goal of both, as I said, is patient comfort. They both rely on interdisciplinary care to varying degrees, and we'll look at the makeup of that team later on. But they always include a physician, a nurse, somebody who can deal with the psychosocial aspects of care, either a social worker or a chaplain or both. And then other members of the team are brought in as necessary in either case. Both types of care are applicable to any disease type. Hospice in this country started largely in cancer, but now in New Jersey, for example, only 29% of our patients have a primary diagnosis of cancer. The rest is anything else imaginable that you can die of natural causes. They're both available wherever the patient lives, although there is a difference in how it gets delivered, and we'll cover that in a moment. And in both cases, they support the family. They don't replace it, with the exception of actual hospice houses, which really account for a very small percentage of patients who live in a facility, hospice residence on a full-time basis. The hospice team makes visits to the family. The palliative care team works with the patient's physician to decide what new services would be provided. There are differences. Jean, shall I do this? Would you rather?
No, feel free, Don.
Okay. This is, as we said, hospice is a type of care, and the graphic shows you what I'm talking about. Hospice is a subset of palliative care. Palliative care is a phrase that's recognized around the world. And in fact, in England, you'll see both of them being used for both types of patients, those who are dying and those who are not yet at a terminal phase. But there are differences between the two, and that's what we'll focus on right now. Palliative care is fundamentally a consultative service to the attending physician. The palliative care team, usually at a hospital, but not always. Sometimes there are community-based palliative care programs. They will provide guidance to the attending physician, who will then use their guidance in deciding the appropriate treatments for his or her patient. Hospice, on the other hand, provides direct service to the patient and family. They visit the patient where they live. Usually that is in the patient's own home, or if the patient is in a nursing home, they'll go there, assisted living facilities, boarding houses. We've had a couple of programs in New Jersey who actually care for the homeless who are dying. So we will go anywhere the patient is. Palliative care applies the techniques while the patient is still in curative or rehab treatment. Under hospice, you forego curative treatment if you are electing hospice. That is a black and white choice that needs to be made for the Medicare hospice benefit to apply. Techniques are applied according to a plan of care, and it is based on visits to the patient in the home. Both palliative care and hospice are interdisciplinary to a degree, but the amount varies. Palliative care is fundamentally a medical model. The physician is very much a part of everything that goes on in a palliative care consultation, and it is treated as a physician specialty. Hospice, while there is a physician certification, is more of an interdisciplinary model. Each of the members of the hospice team, nurse, social worker, chaplain, volunteer coordinator, therapists, they play a larger role in the plan of care than the physician might. The physician in hospice is more there as a supervisor, a teacher, a mentor, and is certainly welcome to follow the patient if it happens to be his own. But the nurse is actually the case manager in the hospice model, not the physician. Palliative care can begin at any time, even at the absolute outset, the diagnosis of the disease. Hospice, on the other hand, requires the patient to be terminally ill with a life expectancy of 6 months or less. Palliative care can include, and usually does include, curative treatment. Hospice cannot include curative treatment for the hospice diagnosis. Now, if there are other diseases that are afflicting the patient that are not considered the primary diagnosis, they may continue to receive treatment for those and have it covered under Medicare or private insurance. But for example, once you've been admitted for cancer in hospice, you will no longer continue chemo and radiation unless the reduction of the size of the tumor, for example, provides patient comfort, eases the patient's pain. Then they may do another round of chemo or so, but that's not usually the case. More differences. In most states, palliative care is undefined in state or federal law. It is not defined in New Jersey law. And that's one of the reasons why we can't be quite so specific about what palliative care is, because a lot of it depends on the practice of the individual palliative care physician and what he sees as appropriate. It's much more a form of medicine than a highly defined discipline, as opposed to hospice. Hospice is defined by Medicare, the hospice benefit, by state law in each of the 50 states. So it is a quite well-defined practice. We said before, palliative care is physician-driven. Hospice is largely nurse-driven. The team may vary in palliative care, but the physician plays the largest role. The team plays the largest role in hospice. Another big difference is that palliative care need not be consciously elected by the patient. It may be something that's prescribed by the physician. In hospice, by law, hospice care must be elected by the patient or the patient's representative, because the patient is giving up curative treatment. And under the law, you have to be very specific about that the patient knows the fact that he's giving up curative treatment. You cannot be assigned to hospice. You have to choose it. Last set of differences, I believe. Palliative care typically does not have bereavement counseling as part of its service. There may be some programs that do, but by and large, not so. Hospice bereavement counseling must be offered up to 13 months after the patient's death. Notice I said offered. You can decline it. I've declined it twice in my own family, but it is there. Nowadays, it is largely group counseling done by the hospice rather than individual counseling, but even that can be called on in many cases. Palliative care usually doesn't provide housekeeping assistance. Hospice generally does in the form of a home health aide. The housekeeping assistance is limited to care related to the patient and the terminal illness. So toileting, changing of bed sheets, things of that nature, and moving the patient, anything that is related to the patient's care can be done by a home health aide. Those are assigned by the hospice based on need. If you've got a family with a patient with a ton of family around, they may not assign a housekeeping aide because there are so many people there to help. Medications and equipment are billed separately under palliative care. They are included within the hospice benefit with a small copay. And hospice also makes volunteers available to provide for patient visitations, just to provide comfort and companionship to the patient, to run errands for the family, to help out around the house if the family so desires. So those are really the differences between the two types of care, but you can see there's a lot of overlap. Jean, you want to pick it up?
Sure. I just happened to see we had a question that maybe we could answer right now related to palliative care. So palliative care is an approach to pain and symptom management. So when if there's a palliative care program or a palliative care physician or palliative care specialist, they are the experts in managing pain and symptoms. And then in addition, depending on the type of palliative care program, there may be palliative care social workers and palliative care chaplains. And so they would specialize in helping the patient and the family look at resources that might be needed to help alleviate kind of the suffering that goes along with all the environmental components of the illness progressing, as well as the psychosocial components for the whole family. So the question is, how do I engage in a palliative care program? And there are, I know on our website, and I imagine on Don's website, that there might be an ability to look for a palliative care provider on the website. That's one place to go. But you could also ask your primary physician or your specialist if they had a recommendation. So it is different than the person that you see routinely for your illness, unless they happen to have gone and gotten a special certification or have this special program available.
There is one other resource that you can use to identify palliative care programs. There is a website called Get Palliative Care. How much easier can it be to remember? Yeah. Getpalliativecare.org, O-R-G. That's run by the Center for Advancement of Palliative Care. But you'll see that you can look for them by state, by zip code, and all of that, and they will list all the palliative care programs serving your facility, your community. By and large, they will be based at hospitals, since that's where most of the action really is right now. There's an increasing amount of palliative care in the community, which is a great thing, but that's the single best resource of identifying palliative care programs for your community. Getpalliativecare.org.
As you or your loved one's illness progresses and perhaps you engage a home care provider, that can also be a good resource. Some home care organizations have palliative care programs as a component, so that provides an extra level of expertise while you're on home care, or they work with the hospice program to work together to create a palliative care component. So hospice, I think what we're trying to say in this slide is this is all about choice. So you could choose to be on hospice, but if you decided that at any point this was not what you wanted any longer, there was some kind of aggressive treatment that you felt was going to fit for you, then you would what's called revoke from hospice. And then your Medicare would be, or your other insurance would fully engage again, and you would be discharged from hospice. While you're on hospice, there are certain benefits that are available to you. You may qualify for continuous care, which means that should something happen and your needs are requiring more frequent nursing intervention, then you may qualify for continuous care. Or if there was something that required, maybe normally it would have required a hospitalization. Hospices have an inpatient component. So they may have their own inpatient unit, or they may contract with the hospital where the hospice continues while you are receiving the services that you need in that setting. So for example, if someone needed frequent medication changes and there was too much for the family to be able to manage, it was so rapid, the need to change those medications, then you might go to an inpatient unit so that the professionals could assure your comfort round the clock. And then there's also a respite care benefit as a part of hospice. So it's been used for a variety of reasons, but sometimes if the family needs a break to kind of catch their breath again, so that they might be able to then assure they're able to stay with the patient through the end. Respite care is a time limited number of days that is available, but sometimes it can also be that the wife of a patient is going to go out of state for the grandchild's wedding. So that might mean that the patient can go and stay at an inpatient unit while the other person, the caregiver, can attend an event. So those are just examples of how that might work. And then, of course, there's always a 24/7 component to nursing availability, staff response as someone has questions or has a need for a nursing visit again. And the doctors are available as well 24/7. Okay, Don? As Don said, palliative care is not a benefit, if you will, under Medicare or Medicaid for New York yet, but we're working on it. And part of the reason for that, as Don said, is because it's not clearly defined all the components that have to be provided. So it's difficult to set up a quote benefit. There might be pieces of palliative care that are reimbursed by different types of insurers, or different programs have set up different contracts, which is why we suggest you go to the website to look for what's available around you. And there are more palliative care providers in the hospital because there is physician billing that's accessible in the hospital for these palliative care consults. So, okay. So when someone elects hospice, probably 92% of the time, they're using the Medicare hospice benefit, and the hospice itself bills the Medicare. There's no billing that goes to the family unless the family decided there was something special, or the patient decided there was something that they were choosing to continue to receive above and beyond what the hospice would cover. But there's usually no bills whatsoever. And Medicaid and other private insurers follow the Medicare hospice benefit rules the majority, almost all the time. And then hospice is provided by, in New York, these hospices have approval from the state. There's a limited number of hospices in our state under a Certificate of Need program, and these are all community-based agencies. Okay. So who is that hospice interdisciplinary team? I'm just going to quickly review these again because it is kind of the This is the gold standard of care. This is really when care wraps around the whole family by this interdisciplinary team, from the medical director, who is a palliative care expert, a nurse, social worker, pastoral care representative, bereavement counselor. There's therapists and nutritionists and pharmacists, consultants, volunteers who can help not just with compassionate visits, but sometimes they're going to pick up the medications. There's a whole host of supports that volunteers can bring. Could be music therapy, pet therapy, anything. Okay. So these are things that we wanted to make sure you knew hospice was not. So hospice is about living as long as you can at the most comfort as possible. It is not about helping someone to die sooner than is natural. So it's not considered euthanasia, it's not mercy killing, it's not assisted suicide. So none of those things equal hospice. Again, more studies have shown that hospice helps extend someone's life than it does to reduce the length of their life, because of the quality of care and the reduction in the suffering all around them. Hospice is not a place, so people don't have to go anywhere to receive hospice services. They can stay where they are in their own home, in their assisted living, as Don said, skilled nursing facilities. So there are, as I mentioned, inpatient units that specialize in the pain and symptom management treatment. And there are some volunteer homes where people at the end of their life can go. In New York, we call them comfort care homes. Some might call themselves hospice houses, but the hospice is the professional organization that goes in to provide the services. There's not a religious connotation with hospice. However, there's maybe some hospices connected to religious healthcare systems. So Metropolitan Jewish in New York City, for example. But that doesn't mean that anyone is precluded from coming onto hospice if they're not Jewish. It just happens to be the ownership of the hospice. And then hospice is definitely not about giving up. So if I could wave my magic wand, I would help all people that worked with anyone who was seriously ill. I would help them with their communication skills, because this is not about giving up, or you fought the good fight, but it's, now it's over and it's perceived as a negative thing. Now, this is about what you want. This is about demanding and clarifying what your wishes are and what you see as your quality of life, and what goals you have for yourself and how you want them to be met. And then there's a whole team to help you do that. So as this slide says, it's all about maximizing the quality of life for as long as possible until the end.
Yeah, Gene, let me make a couple of footnotes to that. On the giving up issue, I was told very early on in my hospice service that sometimes people refer to people giving up hope. And hospice is about creating a different sort of hope. Yes, there's no hope for a cure, but there is hope for comfort. There is comfort that the rest of your life will be free of pain. There is comfort that you'll have the chance to complete some unfinished business in your lives, reunite with family members. It's a wonderful opportunity for that. And all of those things really do enhance the patient comfort. So not giving up is absolutely true. It's about creating a new form of hope for the patient. And the other footnote I'd like to make, and just spend a minute on this, is the assisted suicide issue. New Jersey does have what is called medical aid in dying. Gene, am I correct? You haven't yet passed it up there?
Correct.
Okay. I do follow this pretty closely. In most states, and New Jersey is among them, people have a right of conscience not to participate with medical aid in dying if they choose to do so. Most hospices in New Jersey, it might be all, have chosen not to actively participate in the medical aid in dying program, but hospice is always there for the patient. We are always there to support the patient's and family's needs, and that includes this situation as well. It's an odd situation because the patient is not required to tell anybody that they've chosen to get the pills. They're not required to tell anybody that they plan on taking the pills. So you may have instances where the poor hospice aide gets to the patient and finds that they're gone, which is really unfortunate for the hospice. And we wish the physician would communicate with us, but they can't do so without the patient's consent. So it's a complicated little issue, but the point I want to make is that about, at least in Oregon, which is where this originated, 92% of the patients who do actually take the pills are under hospice care at the time. So they are not mutually exclusive, but hospice may or may not choose to, participate in the medical aid and dying program. So just so that everybody can go into it with their eyes open. It's a brave new world for us. And we're currently exploring whether there is we know that there is a Medicare benefit for advanced care planning. The doctors can get a small amount of payment for counseling the patient about end of life planning generally, including hospice and palliative care. Now we're wondering, can that benefit also used to counsel them about aid in dying? We don't know the answer to that. So there's a lot about this that is yet unresolved, but we're all working on it, and we are working on it to the benefit of the patient and the family to be sure that comfort is always provided. Mm-hmm. Let me go into, I'm sorry, Jean.
I just was going to add one more side note about the fact that hospice, when it comes to self-determination, I think hospice does one of the best jobs of healthcare programs to support the autonomy of the patient and the family in terms of how much or how little not only support and intervention do they want, but all the way to how much or how little medication does the person feel that they are comfortable with nearing the end of their life, and so that the person can remain in control as much as they want. So,
absolutely true. Great point. Thank you. I'd like to spend just a little while on what I've come across in my years as some of the myths of hospice, myths that people have about hospice care, their misconceptions. Some of them we've already touched on. The myth that hospice is a place. No. In England, that is usually true. In England, there are usually hospitals and clinics that are devoted completely to hospice care, and it's a place where you go to die. And that was also the place in Europe way back in the Middle Ages. Hospices were kind of respite places where patients could go to rest on their long journeys, but there were also places where the terminally ill were brought to die. That's not the case in the US. The US has always been, hospice has always been a home-based model with some hospice units here and there. We actually got started largely here in New Jersey. We had one of the first 3 hospices in the nation up in Boonton. And I know the guy who developed that program. He passed just a couple of years ago. But we've always been based in patients' homes, nursing homes, assisted living, a host of other locations. It's a kind of service. It's not a place. 2, hospice is just for people with cancer. That was once very largely true. At the start, we were almost exclusively cancer, almost exclusively suburban. Now our patients are just about everything you can imagine. Cancer, heart, liver, kidney failure, Alzheimer's, some types of dementia, lung disease, you name it. We've got them. Hospice is only for old people. Not true. Most of our patients are 85 and up, but of course we will care for patients at any point in their lives. The harder part for us is that the patients, the very young patients, the kids and the teenagers and the young moms who may be dying of diseases are reluctant to elect hospice because their hope is still so strong that they can return to the life that they once knew. And so they tend to delay election longer than they might. I don't know that that's ever going to change. I don't know of any pair of parents who wants to willingly elect hospice for their child. It's a heartbreaking situation. And what we do in a lot of those cases is provide kind of backroom advice to the physicians that are caring for the patient so that they're still getting some comfort-oriented techniques included in the care without actually going for the nasty old H word. Number 4, hospice is only for people who are actively dying. Not true. I can't even count the number of times that we've heard about a patient dying in the ambulance on the way home to be admitted to hospice. I mean, they elect hospice way too late. The conversations happen in the hospital and the nursing home way too late. About a quarter of the patients, hospice patients in New Jersey, are on service for less than 7 days. In many cases, that's hardly long enough to get the pain under control before going on to the counseling and support that hospice is really famous for. And again, I wish I could tell you the number of times that I've been told by family members, we wish we had elected hospice sooner, but that's absolutely true. And your doc may not always be the first one to bring it up. Very often it's the family who has to. When my wife was dying 10 years ago, the physician would not use the word hospice in our presence. And this was one of the top teaching hospitals in New York City. He had to be encouraged to do so. And finally, when it came time to tell us, there are some decisions you need to make, he left and left us in the hands of a social worker. Bless social workers, Jeannie. So please think about it, long before you think you may need it. It'll do you good. Hospice can only help when family members are available to care. We really do like to have somebody else living in the household with the patient, but it's not necessarily true at all points. Some people who live alone can get by well with just the hospice services. Usually when active dying begins to take place, the last 2 weeks or so, we might encourage them to move to a facility just so that there is somebody on hand for any medical emergency that needs to be dealt with, particularly in terms of pain management. But we have had a lot of patients living at home, and we find a way to manage it. That's what we do. We were the first case managers, and we do it the best we can.
I just wanted to say that
Please.
I think it was key that you said that does a family member have to be there? And for us, family is not blood necessarily. So you may have a community of support people around you. And the goal is that when you need assistance, when you may become at a point where you're not necessarily safe all the time, 24/7, that you have this team of people, it doesn't have to be a person, who are willing to come and support you with what you need. And that's the primary thing, since as the next item there is that hospice isn't there in your home 24/7. That's not part of the benefit. But if you have support systems, then it works perfectly.
Yeah, wonderful point. Thank you. Hospice, is not in your home 24/7. We make visits. A typical schedule might be that the home health aide may make visits for an hour a day or 2 hours a day, 5 days a week. Your nurse will visit maybe once a week at the start, maybe more frequently, and certainly more frequently as the patient declines. You'll also have a visit made by a social worker, and it may be multiple visits if counseling is encouraged. The services of a chaplain may be offered. The family may decline those if they choose. The family may also ask that the hospice chaplain work with the patient's own spiritual caregiver, their priest, their rabbi, their minister, their mullah. We are happy to do any arrangement that provides the best service for the patient. Myth number 7, when hospice calls in the chaplain, it's the very end. The chaplain comes early on, because one of the things the chaplain does, and this is true with my wife, he helps the patient see the value of their life. People at the very end may wonder, did I do everything I could? Did my life mean anything? Yes, it absolutely did. And the chaplain helps you realize that. It helps you in your life review, they call it. So yes, don't be concerned that if the chaplain shows up quite early, because we encourage that to take place. Myth 8, hospice is free since it's charity. No, it's not. But there is a Medicare hospice benefit under Part A, which is very comprehensive. You may be charged a 5% copay for your medications. Not every hospice does that, but most do. But that's the only bill you'll see if you're on the Medicare hospice benefit. Private insurers cover it as well. You may see a somewhat larger copay in those cases, but it's still a very good bargain in terms of healthcare. Number 9, hospice care is expensive. It absolutely is not expensive unless you are doing total private pay, which is like maybe 1/10 of patients are private pay totally. We also provide an awful lot of charity care for families who really are uninsured and cannot afford other types of care. In New Jersey, we do about $4 million a year in unreimbursed care, charity care. Myth 10, hospice is not covered by managed care. It absolutely is covered by managed care. We may see more of that as the years go by, but yes, it's absolutely covered by managed care and under Medicaid as well. The last 5 myths I'll talk about. Hospice can't do complicated cases. We absolutely can. We are experts in pain management, in symptom management, and we are certainly able to care for those complicated cases at home. Hospice is just for when you're ready to die? No. Hospice is when you want to choose comfort as opposed to continuing curative treatment. Hospice may help you get ready to die, prepare you and counsel you and comfort you and prepare your family and let you know what's going to happen. In a lot of cases, we're able to do that just because we're so familiar with the disease progression. 13, hospice will make me die faster. Absolutely not true. We neither extend nor shorten life by artificial means. And in fact, the research, particularly done out of Duke University, has shown that when patients with similar symptoms are in hospice or not in hospice, the ones on hospice will usually last about 11 days longer than patients with similar symptoms who were not under hospice care, which makes perfect sense. I mean, you've got all these folks coming in with all of their services simply to make you feel better. So, naturally you're going to last a little bit longer usually. 14, hospice will make me give up my own doctor. Absolutely not true. We always encourage the involvement of the patient's attending physician. Sometimes the doc doesn't want to take part. And I found this with my father-in-law, who had both cancer and a weak heart. His cardiologist didn't want to have anything to do with hospice. Just wrote it off. He thought, hospice was all about failure and he didn't want to be associated with that, which is fine. Hospices have a medical director who step in those circumstances. They can work as the patient's physician if the patient's physician doesn't want to. But most doctors do want to follow their patients, and we very strongly encourage that, and we will work very closely with them. 15, hospice is just for when there's no hope. Well, we addressed that a little bit earlier. Hospice helps transform hope into a hope of comfort, into a hope of completing the unfinished business of your life, hope that the end will be comfortable and not painful, and you can live until the very end surrounded with your family in your home with the life that you've come to love. Jeannie, you want to talk about advanced directives?
I'm going to just briefly talk about that because I think your previous presenter shared quite a bit about the advanced directives, and from what I gathered, she did a great job. So again, part of hospice is having conversations, and you can have those conversations and should have those conversations when you're healthy, as long as when you've been diagnosed with an illness, and all the way through as things change in your health. So advanced care planning is the conversation about what it is you want, what your goals are, who do you want to speak to you. And the advanced directive are the actual documents that you can use to help make your wishes known. So these advanced directives help to assure that the treatment that you receive is the treatment that you want. So a healthcare proxy is the designation of someone who can help to make decisions for you when and if you are no longer able. You can give more detailed wishes in a document like a living will. And then as your illness progresses, the details on an advanced directive get more specific. So you would work with your physician, and in New York, you would help to create what's called a MOLST, the Medical Order for Life-Sustaining Treatment. And I assume New Jersey is a POLST.
Yes, but practitioners' orders for life-sustaining treatment, not just physicians in New Jersey.
Oh, nice, nice. Okay, so these forms identify this very specifically in terms of intubation, not just resuscitation, but intubation, whether or not the hydration, nutrition, any other likely aggressive treatments that might end up being offered to you as a result of your personal illness could be clearly identified. And it's written as a medical provider order, so that should you be in a position where, let's say 911 is called and emergency personnel come to provide treatment, these forms are actually doctor's orders that tell them what to do and what not to do to assist you. 5 Wishes is a great program to be able to use, and so is the Communication Project, where you can, there are free forms that help you start these discussions with your family as well, because it does us no good to just think in our heads about what we want if we haven't communicated our wishes with anyone. You know, that's where it all comes. The rubber hits the road when it's your family or your friends who are asked to make decisions for you, and they're not trusting that they fully understand what it is you want.
Yeah, the communication process is so terribly important. There is a national event called National Healthcare Decisions Day, which is April 16th. Think death and taxes. And when people are encouraged to really sit and discuss with their family what their end of life and late life wishes are. I happen to sit on the Medical Society of New Jersey Biomedical Ethics Committee, and we met on Thursday, and one of the topics for discussion was the number of new legal cases, lawsuits that are being brought about by families whose loved ones' wishes were ignored by their physicians. The information was there in their advance directive, and the physician just didn't follow the advance directive, and the family sued. This is happening increasingly across the US. So these advance directives are going to become more prolific. And lawyers are going to be advocating for them just to protect their patients and to be sure that their rights are respected. Brave new world out there. Where do you look for hospice and palliative care? We've mentioned with all these before, but certainly you start with the patient's own physician. A discussion of what kind of care is appropriate. Should we be looking at palliative care? Should we be looking at hospice care? And lots of times, and this is awful, but you may have a lot of trouble bringing that conversation into play with the physician. The physician is going to come from the perspective of not wanting to take hope away from the family, but a little bit of gentle prodding. And the simple question, which we always ask, is, Doc, would you be surprised if mom were to die in 6 months? And if the doc says, no, I wouldn't be surprised, that's your green light to start talking about hospice. talk about it in terms of life expectancy. And if that's the case, would the doc make a referral to a hospice or to a palliative care program? There are some websites on here that will help you identify more about hospice. NHPCO is the National Hospice and Palliative Care Organization, which is our national group. My own organization is Home Care NJ. Jean's is HIPCANYS, HPCANYS. And we mentioned the palliative care website below, getpalliativecare.org, run by the Center to Advance Palliative Care, a terrific resource too. And that's us.
Yeah. So we did have some questions in the chat. I don't know, Julia, if you're wanting to lead us through this section.
Okay, I can't see that while the slides are up, so there we are.
So I'll just start with the questions that came first. So somebody asked, are there hospice/respite centers in that specialize or more familiar with MSA in New York/New Jersey? And can you help with providing a list?
I'm not aware of anyone that would specialize in that, but I imagine that your provider themselves might know who they're comfortable with and who's had experience with their patients in the past. I think that's a good place to ask.
Yeah, I think most hospices will have experiences in related illnesses, neurological diseases, things of that nature. So there may be things that are appropriate that can be brought to bear. And remember, we're not treating the disease. We're treating the symptoms, the provision of comfort, and those things apply to every patient everywhere.
Absolutely.
And if palliative care is physician driven, can the patient directly call on the palliative team?
That'll depend on the individual practice of the team. I expect so in most cases, or at least certainly the nurse. The nurse will play a large role in managing the care. But again, it'll depend on the wishes of the individual palliative care team.
Yeah. Again, if it's not only who's in the team, but where is the team located? So is this a hospital-based palliative care program? Is it an outpatient where you can go and get a consult from a physician? Or is it a team-based palliative care program that maybe is community-based through a home care or some other hospice has palliative care extensions to it? And so that might determine kind of how the interdisciplinary workings happen.
And we have another question here. How would a person with MSA qualify for hospice when there's no way to know how long he or she will live?
Well, that's true with every patient that we've got. I mean, nobody's got a crystal ball. It is the only determinant is that the physician must certify that the patient has a life expectancy of 6 months or less, not certainty, expectancy. If the doctor reasonably thinks that the patient could die within 6 months, they'll be admitted to hospice care. The patient the benefit can also be extended. If the patient survives the 6 months and gets to that readmission point, the doctor can say, I still believe he's going to die within 6 months. They can get another 6 months on the program, and that can be extended in theory perpetually. It doesn't often extend that long because Medicare does not like to see an extraordinarily long length of service in hospice. Years ago, we had one patient in New Jersey who was on for 7 years. That would never be the case these days, but you certainly can live beyond the 6 months and still have your hospice care provided to you.
And I think the hospice professionals, the physicians who are asked to certify the life expectancy projection, they are also experts in looking at historical information versus your situation today. So what was your life like, and what were your health care needs and symptoms 6 months ago? What was your weight 6 months ago versus what it is today when you're when we have the hospice referral in front of us? So they compare a short time span previous to where it is today. They're combining physical information that is provided through your physicians, but also with eyes on from a hospice nurse. So they take into consideration everything from activities of daily living, the eating, swallowing, weight, any types of pain, um, all symptoms. It all gives a picture. So there doesn't have to be a straight line trajectory.
And are there specific things they should look for when deciding a palliative or care service?
Honestly, to be able to claim that it's a palliative care program, then the individuals have knowledge and expertise in end of life care symptomology, so pain and symptom management. So uh, for me, off the top of my head, I would say the expectation is that they are, the individuals are able to look across the healthcare continuum at all of the prescriptions and interventions that you're receiving, and can give consult into how best to either use what's there or add something that's going to improve your quality of life and reduce your suffering. So the term palliative care program, it's not necessarily going to tell you exactly all the players, but it should tell you the outcome, which is the ability to reduce the suffering.
Yeah, and a lot of it, I think, too, is the person. Forgive the phrase, the personality of the program that you're looking at. So if your doctor says that he wants to bring,
Don, we're not hearing you.
I'm sorry. Can you hear me now?
No, still very low.
I don't know how to adjust the mic here, so. Well, if you can hear me at all, my advice would be that if your doctor's talking about a palliative care program, ask him to recommend several, and then you call them and see who you're most comfortable with. I mean, that's really what all this is about anyway. So engage each of them in conversations, and that's also true with hospices that you may be talking to. Call a couple of them, find out what they'll do for you, and make your decision appropriately.
Except in New York, where you may not have choice of hospice provider based on where you live. As I mentioned, New York is a certificate of need program. So that means many of the counties of New York have one hospice provider. So there could be urban areas that have multiple, like New York City. And definitely I would encourage you to see where you feel you fit the best. But in other parts, there may only be one hospice provider.
Yeah, in New Jersey, for example, we've got a couple of counties where you can get services from 17 hospices. So you certainly have your choice.
We have someone here asking, when dealing with such a debilitating illness, there may be unique issues throughout the final decline. So, in general, are there any agencies that specialize in certain kinds of medical illnesses like neurological?
Hospice, I would say that you wouldn't find a specialty unless in a particular population there was a high uh, number of individuals with a certain illness. But hospices, they can treat and support people. And forgive me for not knowing all the specifics of your illness, but I can say that Parkinson's, ALS, other severe neurological progressive diseases, any hospice can support individuals and their families who are helping someone near the end of their life with those issues, because it all kind of, at the end of your life, the abilities or inabilities that are a part of a neuro disease are sometimes similar near the end of life.
And let me just add, and I'm sure Jean will concur with this, the hospice teams are very imaginative in terms of problem solving. You know, if they see a patient having a symptom management issue or pain issue, they're going to find a way around it. I was on staff about 2 weeks, and my wife came home, who was then running the Home Care Association, came home and said, "You hospice nurses will do just about anything for your patient, won't you?" Well, she had been listening to a hospice nurse teaching all day and was just amazed at the degree and the imagination that our people can use in solving some of these problems. So don't let that discourage you that you can't find a specialist, because
Right.
our guys can do it.
And the other thing, so for example, I know that communication changes through the course of the illness, and there may be an inability to communicate, but a very cognitive awareness. So hospice will bring in specialists, and they'll use every resource, a speech therapist, anything that we need to assure that you can still participate as fully as possible. So I would say that it I've had hospices hit up charitable organizations to purchase new speech devices, iPad app programs, special even special energy programs to assure that the electronic equipment that's in the home can be supported through emergencies, anything and everything to assure that if your wish is to be home through the end, that it can happen.
And somebody asked, at one point in a patient's progress, would one call in hospice, or when should they start to think about having hospice?
Talk to the doc. It's his home.
Yeah, and I think it's a perfect question to say, you know, as my provider, my doctor, my whoever your specialist is, to say, you know, I heard this presentation and I'd like you to let me know when we are getting close to this conversation, or I'd like you to let me know that you're seeing me more frequently, or that there are shorter periods of time in between my need for an increase in medications or new intervention or something like that. And then when those windows start to get closer and closer, you know, I want you to know, doc, that I want to have these conversations, because as Don said earlier, sometimes there's a reluctance and a fear to bring up information that you might find uncomfortable. So anything that you can do to help keep that that door open, to say, I want these honest conversations, and I want to know, like, way ahead of time, you know, as much as you can. And part of that is, as I said, sometimes that just comes from knowing the frequency of hospitalizations, of increased medications, change in your status, declining and not plateauing, or your next level of plateau is continuing to be different. So.
And we have another question here. While in palliative or hospice care, is there any support available to care partners and especially children of the patient?
What do you mean when you say support? Do we know that?
Can the person who asked this question clarify what they want to know?
While we're waiting for that part of the equation, I can tell you that there's definitely one of the responsibilities of the social worker on the team is to also look at the other family members. And well, everybody is looking at all the other family members, but in terms of supports that might be necessary for children, we've worked with different school districts, we've worked with children's counselors, and there are children's bereavement groups that many hospices run to help the child understand what's happening. That's definitely a component of hospice care, to make sure that those that are around the children, whether it's their church, their school, the rest of the family understand where the child is at in their understanding of the illness, and then to help the children post-death. Those are all components of hospice care.
You know,
And
on the other hand, you know, in terms of support, if it's an elderly person who needs support, because we have loads of cases where, you know, the wife's 90 and the husband's 92, and they really are having trouble with it. There are other resources in the community. The Office of Aging might be able to help. In more severe cases, you may want to look at a nursing home placement for the two of them so they can stay together and yet have additional support around them as they, you know, live out their final years.
And so the person who asked the question clarified, asking if there's any counseling for like respite for care partners and children of the patient.
Sure. So I think that that also goes to the role of the hospice social worker to offer that level of support to the caregivers and to help the caregiver as the individual patient's needs increase, the caregiver needs may change as well. And so they're a team to work together to, maybe it's not something that is necessarily purely emotional, maybe it's practical, maybe it's additional help that's needed. So the social worker might work with the caregiver to access supports from their community, to be able to give a list of tasks to fellow family members who can help, you know, to help them put a plan together that supports them. And sometimes that is respite. So yes, the respite benefit can be used so that the caregiver, as I mentioned earlier, can feel that they can breathe a little bit and reestablish their plan and know they have the strength to carry on.
And someone else asked, if a person is in long-term care and the end is imminent, can family members be permitted in to be with their loved one? I'm aware in another state recently, a family member was told it was against protocol and could not be with his wife when she passed. Is it different from state to state?
It's not only different from state to state, it's probably different from facility to facility. And of course, now that we're in the COVID crisis, the rules are all different anyway. Too many long-term care facilities are still only allowing window visits. They're not allowing the patient to be actually in the room with the family member, unfortunately. The issues of contagion are just still too great at this point. So the rules right now are probably different than they generally are.
And I think in terms of hospice, if someone were on hospice in a nursing home and a family member wanted to be with them, we would help advocate for that, but we wouldn't have control of that. So,
Yeah, the nursing home has under federal law, the nursing home has the absolute right to control what happens under its roof. And there's just no getting around that. As Jean said, you advocate as best you can, but you may have to put up with a window visit or a Zoom visit. Or they have some, where have I read this? I don't know if it's in the US or not, but they are developing these overall body wraps that the family member can put on and go into the room and hold the patient through the wrap so that there's no actual physical contact. Like I said, we're having to use a lot of imagination, but you know, simply you do what you can.
and I think that there's always, again, if that's the desire, and then you have to weigh the pros and cons of okay, if I'm not allowed in, can the patient be moved somewhere where I would be able to be with them? So, for example, there was a patient in New York in a VA nursing home, and the family wasn't allowed to be with them. The patient signed himself out, and he went to a hospice inpatient unit so that the family could be with them. So I don't think we can stress it strongly enough, Don and I, that when hospice is elected, you have a lot of brain power working on every resource available to make sure that your wishes are fulfilled.
And while we wait for some more questions to come in, I'd like to chime in and ask something myself. So, hospice at home versus hospice in a facility, what are some differences that one could expect in terms of level of care?
Go ahead.
I think the first thing I would say is that when hospice comes into a facility, nothing in the facility changes. So there shouldn't be a change in the nursing support on the floor, the CNA, the certified nursing assistant support, those types of things. What hospice does is add a layer of support. So they add nursing oversight so that the hospice nurse that comes in may not do all the direct hands-on care, but what they're doing is assuring that your pain and symptom needs are managed to the best of our ability. So it may not be the specialty of the nursing home to understand how at end of life, different medications, different interactions happen. And so the hospice nurse works with the hospice physician to tell the nursing home, we recommend you do X, Y, and Z. Please change X, Y, and Z for the patient's comfort. And so it adds a layer of consultation and support. And then an aide might also go into a nursing home, not to necessarily take over the personal care, but to add that special care that a person at the end of their life may not get from the nursing home team. So added time for feeding. So it's starting to take a long time, and the people in the nursing home are so busy they can't take more time with the person to help feed them. So the hospice home health aide may spend the time to do that, or to do the person's hair because there isn't an opportunity to go get that done in the nursing home anymore, and those types of things. So it's an added layer of support from all those disciplines.
Yeah, and if I could just add, one of the things that Medicare is very conscious about is that the level of care that a patient in the home receives is the same as the level of care that someone receives in a nursing facility. Their feeling is that the nature of your care should not vary based on where you are, because if we do that, they're going to want to pay differently in the two locations, and we don't want them to do that. So what we're really talking about is the nursing home generally provides those services that the family would provide at home. Hospice provides the additional level of care in each case. I think the big difference, to answer your question directly, is just the ambiance is going to be really different in a facility than it would be in a patient's own home. And if there's a difference in how the patient feels, I think it's largely the result of that, rather than any specific differences in the services that are provided. But Jean's points are entirely accurate. The additional level of care that you get in nursing may be conceived or perceived more by the patient than in the home, where people are in and out all the time.
And someone commented regarding the visiting long-term care patients that during the pandemic, the rules have been a little bit more liberalized since the patients have largely now been vaccinated. So that's something to keep in mind.
Absolutely.
Yeah,
And hopefully more.
It's interesting what's happening around the country, and amazingly, the number of hospice staff who are resisting the vaccine. We had a long conversation with people yesterday about that, and it's an education that we need to do ourselves, and also with minority communities. There's such a distrust about extraordinary practices like the vaccine that there's a lot of resistance from there as well. So it's not gonna be a magic wand. Not everybody's gonna be vaccinated within 2 months. So it's gonna take a while for all this to pan out.
Someone would like to thank the speakers today in MSA New Jersey for this conference, as it was really helpful and appreciated, and to have this support.
Thank you.
It's a pleasure to be with you.
I see someone has their hand raised in one of the participants, so maybe they want to type their question or comment into the Q&A.
Okay, I see a question here. Seems like a dilemma for hospice that a large percentage of assisted suicides in New Jersey are chosen by hospice patients. I don't think it's not a dilemma for us at all. We need to respect the patient's wishes. It is law in New Jersey. So if they choose to take part in the medical aid and dying program, we will be there to support the family and support the patient as appropriate as we would be anyway. So this really does not present a dilemma for us.
So it is 2:00, which concludes the end of this conference. Thank you everyone for attending, and thank you to Donald and Jean for participating in today's conference.
On behalf of MSA-NJ, yes, thank you, Donald. You always do a wonderful job presenting at our conferences, and welcome aboard, Jean. We're happy to have the New York perspective as well, so thank you. Julia, fantastic job today moderating. We really appreciate your help. And to our attendees, once again, thank you for participating and your continued support of MSA-NJ. Remember, we have our last session held next week with MSA-NJ board member Joellen Fox and her colleague Lauren Zaloff, discussing ways to stay engaged and active throughout the pandemic. Hope to see you next week. And thank you again, everyone. Have a great weekend.
Thank you. Take care.
Take care.
Bye.
Bye-bye.